Good afternoon, everyone. My name is Amanda Poloview. On behalf of Lung Foundation Australia, I would like to welcome you to the final Pulmonary Fibrosis webinar in this year's series, which is presented in collaboration with the Centre of Research Excellence in Pulmonary Fibrosis. We are pleased to have Deborah Sandford joining us today to present on the emotional impact of IPF. I would like to start by acknowledging the traditional custodians on the land on which we live and work, and pay my respects to elders past, present and emerging. We aim for these webinar sessions to be as interactive as possible for people joining us live today. So please send questions through using the Q&A box, which can be found at the bottom of your screen. These questions will be presented to our speakers towards the end of the webinar. Please do not use the chat box for questions during the webinar, as we may not receive these. I would like to introduce our speaker today, Deborah Sandford. Deborah is a clinical psychologist from the University of Adelaide and the Royal Adelaide Hospital, and joins us today to share her knowledge on the emotional impact of idiopathic pulmonary fibrosis. Thank you for joining us today, Deborah. I will now hand over to you.
So, thank you for having me today. And as I've been introduced, my name is Deb Sandford and I'm a clinical psychologist. I have a role at the Royal Adelaide Hospital, the University of Adelaide, and I also have a private practice. Okay. So a little bit about myself. I have obviously no conflicts of interest, and I first became aware of IPF when a lung transplant patient was referred to me at my practice, and it was a disease I didn't, even though I knew a fair bit about lung disease, I did not actually know a lot about IPF. And in order for me to help this person, I had to do some research into it. And the more I researched, the more I realised I wanted to know more. And not only that, but it was obvious from what this chap was discussing with me that it was a terrifying disease in many ways. And even though he came to me after he'd had a transplant, his words to me were, "I needed to see you before." So that was the beginning of my journey. And since then, I've begun some research into into IPF, and I begun a PhD. I've been in private practice since about 2011, and I'm a member of the Lung Foundation Centre for Research Excellence Educational and Subcommittee, and I'm also a CREATE Fellow. So basically, what do psychologists, and what is psychology, and what do psychologists do? And you know, we are both a science and a profession, and we're devoted to understanding how people think, feel, behave, and learn. And the goal of psychology is not to particularly change people, but it's to study human thinking and behaviour, and then be able to put that knowledge into practice to help people, communities and society in general solve day-to-day problems and improve their quality of life. Which is why I'm here today, to assist by answering some questions at the end, hopefully, and also to explain a few ways that how IPF affects people, not just people diagnosed with IPF, but also their loved ones. And just a disclaimer before we go too much further, obviously today's presentation is general in nature, and it's not specific to your particular situation. If you hear anything that I say that upsets you, or you'd like some personal advice on, please let the Lung Foundation know, or myself know, and I'm happy to chat with you privately afterwards. So what are we going to cover today? We're going to cover a fair bit, actually. So we're going to have a look at emotions at diagnosis and beyond. We're going to have a look at the impact that they have on yourself and your loved ones. We're also going to look at the living with the uncertainty of IPF. And if you most of you probably know by now that the disease trajectory for IPF is very uncertain for most people, because it affects each person quite differently, and that uncertainty can be very unsettling. We're also going to be talking about how to talk to your loved ones, not just your spouse or your partner, but your wider circle of support. We'll talk about some strategies for managing some difficult emotions. We're going to talk about that elephant in the room, palliative care, which is pretty much misunderstood by many people. We'll also touch on transplant, and then I'll try and answer any questions that might come up at the end. So emotions at diagnosis and beyond. So you all will have had some sort of emotional response at diagnosis, and that reaction is very normal and natural, and some of the more common ones that we see people describing are listed here. And as you can see, more what we would call a negative emotional reaction than more of a calm or accepting, which is more of a positive emotional reaction. And one I haven't got there is grief. And in a few slides' time, I'm going to talk about grief a little bit more, because many of these negative reactions that we have listed here are actually aspects of a grief reaction, and are not pathological, but are a very normal reaction to bad news. So before we go too much further though, let's have a little bit of a look at what actually is an emotion, or whatever it is. And so thought comes first, and then the emotion comes later. And with that thought, we have thoughts are our mental cognitions. So they're our ideas, opinions, beliefs about ourselves and about the world around us. And they include, they're our perspectives on life. So we've been developing those since the day we were born, and they're an attitude or a schema. So babies are hardwired to learn, and as they learn about the world, and as your individual particular circumstances will be different than the next person's, you will develop slightly different schemas. So if you saw someone running down the street, for instance, your immediate thoughts, your attitudes, or your internal schemas, your internal working models would probably start to ascribe the reason why they're running down the street. Now, if you'd been brought up in a war zone, for example, you might think, oh my gosh, they're being chased, there's an explosion, they're running for help. If you'd been brought up in a country town, you would think something completely different. If you'd been brought up in the middle of the city, again, you might interpret that situation completely differently. And depending upon what that person was wearing, you might also interpret it again very differently. If they were a well-dressed businessman or a woman, you might think, oh, they're late for a meeting. If they were covered in tattoos and wearing leather, black leather, you might think they were running from the police and they were a bikie or something. So we use our internal working model to develop our thoughts. And when we have a thought, that turns into an emotion or a feeling. So if we'd seen that tattooed black leather man running down the street, you might have felt fear or concern or distress. If you saw a small child running down the street, you might look around for the parents, and then you might experience worry or danger for that small person. So feelings, are of course that flow of experience, and some of those are listed that you can read. And I probably won't read the exact words that you can see on your screen, because if that's what we wanted to do, then you would probably just be able to read the PowerPoints and not have to listen to me. And my arrows have disappeared. So each person will have happiness, sadness, joy, anger, fear, but we all experience them slightly differently, as I said, depending upon what each of your emotional experience, your internal schemas are like. And if I'm looking down at the side of my screen, it's to try and find my arrows, which keep disappearing. So emotions are contagious, and as you can see by this little person in the corner of our screen, most people, when I show this photo, immediately smile, or they get a warm and fuzzy or a soft feeling inside. So they are contagious. We tend to mimic each other's outward states, and that can be a good thing. It can also be a bad thing. Emotions are dependent upon your cultural traditions, your genetics, but also your physical health condition. And today we're going to be talking very much about how your physical health, or your diagnosis of IPF, or your loved one's diagnosis of IPF, can actually influence how your emotions how you feel your emotions. So emotions aren't to be feared. They are a normal and a natural part of everyone's life. And in terms of them becoming what we would call clinically concerning is when you have very strong emotions, generally a very negative, the more negative emotions, where they begin to impact on more than one area of your life. So where they have a more invasive aspect to your world. And so, but even if they're not that bad, if they're not clinically concerning, they can still have a reasonably important role in the way that we cope with our illness. And there's quite a bit of research out there that has shown for various different diseases that the higher the emotional distress that someone feels, the more negative the impact is on their physical illness, and that is regardless of disease. So you will have experienced several emotional reactions throughout your disease course, and for those of you who have had IPF for some time now, or been living with someone with IPF for some time, you will have noticed that often if you have an exacerbation or become unwell, then your negative emotions that you feel will actually generally rise up and also impact on that period of unwellness. So I'm very, very strong on the thing that we should not allow ourselves or our doctors to pathologise something that is a very normal process. And this little picture is from the Disney movie Inside Out, which is all about feelings. And if you haven't seen it, I encourage you to watch it. It's a delightful movie. But IPF can and will have an impact on your emotional process. And I'm not saying that people don't suffer from anxiety or depression with IPF, but you are more likely to have normal grief reaction, and you can also have what we would call comorbid depression and anxiety. So just because you're feeling sad or worried does not necessarily mean that there is something particularly wrong with you. So a few slides ago, I said that I was going to talk about grief, and most people have some form of grief reaction when they get bad news. And so that's not just about a death or someone we love passing away. It is when we would lose our job, divorce, separation, and also when your doctor says to you that you have a disease that is life-limiting. And so IPF certainly meets that criteria, and most people will have some form of a grief reaction. And grief is actually quite a useful reaction because it helps us to adjust. Grief isn't necessarily all bad, and this is a little diagram from Peri Accoyle. She is a researcher who at Stanford University in America, who really talks, has done a lot of research into grief and how it affects people both in a well and unwell populations. And specifically in an unwell population, she looks at two types of grief. So she has the loss-orientated grief, so that's the very sad part of the grief reaction that people are quite well aware of. But then we also have, on the opposite side, the restoration-orientated grief, which is the grief that you help add meaning to your life. So when you think, I'm going to make the most of the time I have left, or my disease has made me a stronger person, that's that sort of type of grief. And both of those put together actually are part of that adjusting process. So we have another model of grief, which you may or may not have seen in the past, and that is what we'd call the Kubler-Ross. She was one of another quite a famous researcher into grief, but admittedly she did predominantly look at grief through death or loss, but equally we can see that this cycle of grief is quite appropriate for many people who have had a diagnosis of IPF, or you have a loved one with a diagnosis of IPF. The chart on, I'm not sure whether it's your left or right, but the blue wavy looking chart is probably my least favourite. I like the one with the starry arrows the best, because we do tend to go in and out of the different stages of grief, and that can be quite quickly, or it can be over a matter of days, weeks, or hopefully not months. So is it grief, is it depression, or is it both? Well, one of the quickest ways we can sort of figure it out for ourselves is that grief generally comes in waves. So if you're standing there doing the dishes or just sitting quietly and the emotions come up and hit you like a wave, then you're probably having a grief reaction. If those emotions that make you feel flat and low are there on a more constant basis, then we would probably be thinking that we might need to look at a diagnosis of depression. And you should not say that you're depressed unless you you are diagnosed with it, because clinical depression is just very different from feeling depressed for a short period of time. If you would like to talk to someone about it, of course, your first stop is probably your GP, and they can write a referral out for you to see someone like myself, a clinical psychologist. The Medicare, the federal government has an initiative under the Medicare scheme called Better Access, which does allow you to have up to 10 sessions with a psychologist in any one calendar year. And if you'd like to talk to your GP about it, they will be able to give you much more information about how to access a referral to a psychologist. So the impact that IPF has on yourself and your loved ones can be quite profound. And again, we're coming back to thoughts and emotions and how those two things work together to have an impact on you. And like we spoke about earlier, and I think I'll mention this again at some point during our webinar, thoughts trigger emotions. So the thought comes first and then the emotion comes second. Often we become aware of the emotion before we actually think about the thoughts. And those thoughts are sort of just like self-talk and auto thoughts. And for a lot of people, they just sort of swirl around at the back of your head, not really being very obvious, but they are obvious enough to your brain because they actually have an impact on how you feel. And that's really important, because how we feel will have an impact on how we manage being diagnosed and living with IPF. And it will differ from person to person. Now, psychological distress for people it's not always obvious, and it might not come immediately. Sometimes these things will take days, weeks, or even months to sneak up on you. However, the degree to which you experience psychological distress will be different for all of you. Some of you will have quite a significant impact, and others will have a lesser impact. And that will all depend upon the severity of your illness, your internal schemas that I touched on earlier, your what we would call resilience, how you're able to accommodate and adjust to your new normal. Also, it's about how your caregivers and what support systems you have around. So for each person, it's a very different trajectory. but it can cause significant and ongoing problems for many. And in fact, I suspect that for a lot of people that would actually be the norm rather than the exception. We do know, and I know from my research, that for many, many people, not just the person with IPF, but also the people that are around them, their loved ones, they feel under-supported. And we are actively, not just myself, researching how we can better support people with IPF, but the Lung Foundation and many other IPF respiratory departments throughout the country are also actively looking at how we can make that a lesser experience for most people. Psychological distress, as I said, is often connected with an exacerbation, but not always. You might have IPF, or your loved one might have IPF, but life goes on. And so psychological distress can sneak up on you because other things in your life are happening that, that might just be the straw that breaks the camel's back. And the impact that it has on not just your capacity to be able to tolerate your medications and do other things that will help you through your IPF journey, but also on your mortality and your morbidity. So but making sure that you have good psychological supports and support systems around you is absolutely imperatively important, because as you do become, as your symptom burden does increase, your health-related quality of life generally decreases, and that's where we find lots of loved ones also being affected because your roles change. And whilst these photos are a little bit tongue-in-cheek, I have had an 83-year-old woman tell me that she was up the ladder cleaning out the gutters for her the first time in her life the other day because her husband, who usually did that sort of thing, no longer can. And conversely, I've had men who haven't done very much cooking in their life finding themselves now taking over that role simply because the wife who normally has done that really finds standing up and being on her feet for a long time quite challenging. So we do find those loved ones' life roles really changing dramatically, and that too can have a dramatic impact not only on the person with IPF but also on their caregivers. So how do we live with uncertainty? Well, we have to get a good handle on our new normal. So initially, when you are diagnosed and you're getting your head around what that diagnosis means, you might find yourself withdrawing, becoming short of temper, teary, difficulty forming thoughts, memory impairment, loss of appetite, trouble sleeping, loss of self-esteem or sense of self. All of those things, I would say, are completely normal. And so not only that, but the difficulty forming thoughts, memory impairment, loss of appetite, there's a very good psychological reason why that's happening, and it's, if I had a whiteboard behind me I could probably draw for you, but the brain is a very clever thing, and so when it's under load, so when it's under emotional load, it will send some of its workings within, and so our forming thoughts, our memory, and all of those things happen on the outer cortex of the brain, and because it's sent some of its operations within, all of those things are quite normal and would be expected as you are adjusting. Most people should come out of that as they adjust to their grief reaction, and it is really very important, and this this slide that I've just come into is all about how you help yourself and or your loved one to do just that. And so living with uncertainty, it's really important that you do maintain your engagement with your life, and whatever that looks like. Don't let IPF, don't become IPF. It is only one part of you. And for what you have been before you've had your diagnosis, you still are. And it is really important to, as far as possible, try and make sure that you can maintain that engagement with your life. You know, breathlessness, cough, they will change and have a significant impact on how you do this. But, you know, if you develop some strategies and allow yourself to have the capacity to not be maybe quite as active as you used to be and all of those things, they will help you to adapt as you need to. So how do you do that? Well, you do it one day at a time, 1 hour at a time, and one moment at a time. I would urge you to avoid what we call chunking your emotions into your emotional reactions. So if you are, instead of saying I'm having a bad day or a bad morning, try and break it down into moments and give yourself opportunities to maybe come out of that or to start to feel a bit better. And we would call that re-narrating, and it's rather than writing off the whole day, we can just maybe allow yourself to have a bad morning, or and even we would go one step further and look at the language and the words that you use to describe that situation. So it might be more realistic to say you're having a low energy morning, or it might be I feel flat this morning, or my breathlessness is bothering me this morning, or I feel exhausted, or I'm really worried this morning. And so when we start to use more accurate descriptive language, our brain hears that. And if we're feeling exhausted this morning, we might be able to then give ourselves permission to sit and read a book, or to just put off sweeping the floor or pruning the roses. Or we might call our friend and say, look, I'm feeling really exhausted this morning. Can you come to me rather than me coming to you? Rather than saying I'm just having a bad day or I'm having a bad morning. And that those words that we use to describe ourselves and our situation will absolutely impact on how we feel about ourselves and our day and our disease. The other thing that's really helpful is, deciding how you want to live your life. Be true to your values, and each of us will have different values. Be patient and kind to yourself, and if what your self-talk is telling you is not what you would tell your best friend, then you've got to give your self-talk a little bit of a talking to, and try and think about how you would talk to your best friend if it was them that had this disease, not you, and what advice you would be giving them. And that is the same advice you should be giving yourself. So my grandmother was a wise woman, and I miss her terribly, but she had a big impact on my life. She was a farmer's wife and a very handy woman, and she was a lovely lady. And some of her favourite sayings were these two: there's more than one road leading to Rome, and Rome wasn't built in a day. And so those two pieces of advice, I think, are very valuable for people diagnosed with IPF, because they tell us to think outside of the box and also to pace, so that there's more than one road leading to Rome. If you want to do something, then the way you used to do it is one road, but there's always more than one explanation. There's always more than one way of doing something. And Rome wasn't built in a day. Well, that's talking about pacing, and that's pretty much my next slide. So pacing is a bit like the old Aesop's fable of the hare and the tortoise. So, don't be the hare, be the tortoise. My favourite example is want to prune the roses or do some work in the gardening. Rather than spending the whole day in the garden, you might spend an hour or a small period of time in the garden until you feel that it's time to stop, and then go in, have a rest, and then come back out again the next day or later on that afternoon. Whereas if you spent and pushed yourself through, that might write you off for the next few days. So if you pace out what you want to do over a period of time, then what you will find is that you will achieve probably about as much as you would have if we count in how many days you would have written yourself off for. So pacing is a valuable gift that you can give to yourself. Now, I really wanted to add this slide in, and I didn't quite know where to put it, so I've put it here. But I think it's a really important part to remember that our breathlessness and our emotions are connected. And if you look at the picture of the brain, or the two brains up in the top hand corner, you'll see I've circled amygdala. Now, the amygdala is part of our limbic system, which some of you may have heard. It's part of the fight or flight system, and it controls our processes, our emotions. But it's also connected with our feelings of breathlessness. And so sometimes when we get breathless and we feel fear, that's because that part of your brain that we would call part of the primitive brain or the reptilian brain, which is right at the top of your brainstem, is firing on all fours, and it's telling your brain that something's wrong, and that's what's happened. Now, how do we talk to our loved ones? It's sometimes one of the more difficult aspects of having IPF or living with someone with IPF. And I really would, there's only one slide in this section, but it's a really important slide. Putting on a brave face is absolutely not a good thing to do. It's rarely helpful, because when people put on a brave face, what it does is it encourages those people around you to also put on a brave face, and it makes everyone feel isolated. No one can talk about anything, and it just serves to make the whole process of supporting and being supported very, very difficult. So finding ways of talking to those people who are important to you is really important. And often that first conversation is the hardest, but once you get going, it will be much more easy. And so do try and share how you're feeling and what you're thinking, your fears and your worries with each other, because again, my grandmother used to say, a problem shared is a problem halved, and in this situation, it is very, very true. And if you still are having trouble doing that, then someone like myself can sometimes help facilitate what we would call family therapy, where we can get everyone in together and help facilitate those difficult conversations. So some strategies for managing difficult emotions. Again, one of the fathers of psychology was a fellow called Sigmund Freud, and whilst he started the conversation about why we do what we do and how we do what we do it. We've all moved beyond Freud now, but he did have a lovely saying, and it's hard to deal scientifically with feelings. But having said that, we've figured a few things out from years and years and years of research. As I said earlier, thoughts come first and then the emotional reactions follow. So when you are having a difficult emotion, it always helps to acknowledge to yourself what you're feeling. Trying to push it away, trying to push it down, trying to ignore it, generally just does the opposite, and it makes that emotion worse. Sometimes you can have a bit of a conversation with yourself and ask yourself, is your mind being a bit of a drama queen? Most people, if they leave themselves just to have their thoughts wander, well, minds like to amuse themselves, and generally they do that with dark imaginings. So are you looking at worst case scenario, or are you looking at best case scenario? Are you in worrying mode, or are you in problem solving mode? Worrying mode will very rarely get you anything other than an increase in feeling sad and feeling bad. But if you're in problem solving mode, you might be able to do, that lateral thinking and think about, well, I really want to do X. How can I actually achieve that? And the last thing we would do is, this is the sitting with emotions. Many times we can actually do what is important to us, and that's that living by your values. Even if we are anxious, we just might have to do it a little bit more slowly, or we might need to call in some of our support systems, our loved ones and our friends, to help us do it anyway. So at the risk of sounding like a Nike ad, just do it. So part of that conversation with our loved ones and our care team should be talking about the elephant in the room. And this is a subject that many people find very difficult to talk about, and that's palliative care. Most people, when they hear the word palliative, they think about the last 6 weeks of life, or must be nearing death, and we think of hospice. Palliative care is very different than hospice care. Palliative care should be started, that conversation should be started early, and palliative care in its modern form is about symptom management, and that IPF is about cough and breathlessness being managed and managed well. And so your respiratory physician should be able to talk to you about palliative care. Now, some of them have done extra training in palliative care, and others might refer you to someone who is a palliative care specialist. So it is aimed at, as I said, managing your symptoms. It's aimed at enhancing your quality of life. It will usually involve a multidisciplinary team, and that will be a doctor, physio, OT, speech therapist, psychologist, social worker, and we will all play a role in making sure that your quality of life is as good as it can be. And there's some fabulous research coming out at the moment from a dear friend and colleague of mine over in America, where we know that if we start that palliative care conversation early, we actually have far better outcomes. And lastly, the palliative care conversation should also involve creating an advanced care plan. And an advanced care plan helps you to have those conversations with your doctors, but also with your loved ones, about what it is that you want to happen as you become more and more unwell. And that can include discussing end-of-life care, including where you are going to die, whether you want to die at home or in the hospital. It helps you to think about what is important to you, and what your values, beliefs and goals are. But and it will usually also involve that personal representative. So someone who's close to you, who understands what your wishes are. Now, you can see from that last dot point that we've got a very small percentage of patients who are discussing end-of-life care, despite the majority of people saying that they would like to. So if your doctor doesn't bring these subjects up, don't be afraid to bring them up to them. So just because doctors are very skilled and great at what they do, they're human, and some of them find talking about that tricky emotional stuff tricky and difficult. And I had a conversation just recently with a respiratory physician who I'm absolutely very, very much in respect to. And she said to me that she found it really tricky talking about sex and libido to her patients because she considered herself quite traditional, and so that was a really interesting conversation. But if her patients brought it up, and she was happy to talk about it, but she found it a little bit embarrassing to ask people who were older than her about their sex life. So if your doctor doesn't bring it up, take your list in and make sure that you bring it up to them, and they will talk about it with you then. So we're coming towards the end, and I did just want to touch very quickly on lung transplant. Now, some of you might be eligible for a lung transplant and others are not. If you haven't had that conversation with your respiratory physician, do. It is something that everyone should have the conversation with, and they will advise you about whether or not they think that it is the time to talk about it, or whether you would be eligible or not eligible, and the process for being assessed. If you do have a lung transplant, I think it is a good idea. I speak to many people who are ready to have a lung transplant, but it's not just a second chance. It getting better, as I said here, might not be all sunshine and roses, because having a transplant actually brings its own set of challenges. You get a new set of lungs, you don't get a new personality, and you don't get a new family, and you don't get a new situation. So most people come out of a lung transplant thinking that because they've been given a second chance of life, they need to do something special with it. Well, that can set you up for a fairly big disappointment in yourself if you don't live up to that. So being realistic in what a lung transplant can give you and will offer you is very important. Your respiratory physician and transplants team will talk to you much about that. In terms of transplant for loved ones and caregivers, the transition from being a spouse to someone who takes care of someone who's very unwell can be a hard transition. But the transition back from being a caregiver to being a spouse, many people find even harder, because they are used to wrapping the person who's been very well up in cotton wool, and that transition can be quite tricky, and many couples find that a very tricky transition to do. So we're coming towards the end. I hope I've given you a potted summary of some of the challenges and difficulties that IPF presents on an emotional capacity, from an emotional aspect for people with IPF and for people who are living with people with IPF. My perfect world future has a psychologist as part of every multidisciplinary team in every respiratory department in the world. So people don't have to have quite as much unsupported psychological distress or emotional turmoil that we currently see. And of course, consultants will then be able to send you to see someone like me as routinely as they would send you to radiology or pathology. And last but not least, you don't have to be crazy to see a psychologist. And as my IPF patient said to me when I first started seeing him, he said, "Deb, seeing you is a bit like having a mental massage." And so seeing a psychologist can be a very safe place to talk about some of these really tricky things. And I'm happy to take questions from here. So thank you very much for listening to me, and I hope I've been of some help.
Thank you, Deborah. It's been really valuable having you join us today and present on this topic for IPF. We'll now open up to questions, so please continue to send your questions through while Deborah is with us today using the Q&A box. So Deborah, my son and daughter have said we should have a discussion of how they can help and what I need. How do I go about this?
Okay, so before you have your discussion, sit down quietly and just get a note paper and start thinking about some of the things that would be helpful for them to be able to help you with, or what you do need, because often when you are face to face with people, some of those thoughts will go out of your head, or you'll be sidetracked into a different conversation. So if you want to, and that list of what you need will change over time, and it will also, you know, when you first sit down to think about it, you might be only able to think of one or two things, but over the coming days or weeks, you might think of more. So I would just start to have a think about what it is that you'd like to say to them, and then maybe, you know, be a little bit clinical and maybe run it like a meeting. So have a bit of an agenda of what you'd like to talk to. So if you find the conversation does get sidetracked, you can always come back and look at your list of what you'd like to talk to them about. Those conversations don't have to be had in one sitting either. So many people find it handy to dip in and out of those conversations, you know, over time.
Okay, we have another one coming through. So at what stage can someone be referred to palliative care from their GP?
So if you don't have a respiratory physician, because you've just said a GP there, is that?
Yeah, that's correct.
So if you don't have a respiratory physician as part of your care team, I would encourage you to get your GP to refer you to one. And then between the respiratory physician and your GP, they should be able to refer you to a palliative care. Now, a lot of respiratory physicians have done palliative care training and or will be able to begin that conversation with you. So, and look, many GPs may have also done it. So ask your GP about it, and the sooner the better, because if you've got symptoms like cough, breathlessness, then some of those will, you know, you may need to begin thinking about how they can be managed.
Thanks, Deb. Can you get family therapy as part as? Sorry, I'll start that one again. Can you get family therapy as part of a mental health treatment plan?
Oh, that's a tricky one. The Medicare rules are quite specific, and sometimes we have to be a little bit creative with how we work them. But if you are the client that we would see, often we will invite people, your support group, into, if you'd like them, into the session, and then we can look at family therapy that way. So yes, but you know, it will depend also upon the therapist you see. Not every therapist has high skill training in family therapy. It's quite a specialised area.
Okay, we've got another one that's come through. Do you have any suggestions for loved ones struggling to come to terms with their loved one's diagnosis and consequent witnessed physical deterioration?
Look, I'm pausing. It can be a very hard journey for people, for loved ones to watch, and often we see, and in fact the research that I'm currently doing is that we've found at diagnosis, the person who's been diagnosed with IPF having quite an emotionally distressing time, and as they accommodate to their disease and actually become more accepting of it, often the distress that is felt by the loved ones increases quite dramatically. And so because they do see them deteriorate, and that is distressing and painful to watch. I would, if you're finding it difficult to do that, I would highly and strongly recommend that you seek someone like me out, where you can talk about your own individual circumstances and get some advice about maybe how that would work for you, because there's no easy one answer for that. But you know, the Medicare mental health care plan 10 sessions is out there. Take advantage of it, and there are many people across Australia who would be happy to help you.
We've got a couple more that have just come through. Pacing can be a big change for some people. Seems logical, but how do people adjust?
that is probably one of the hard, it's one word, it's a simple word, but it's probably one of the hardest things for people to do, especially for people who have been very active all their life. They that self-talk that I've talked about, that voice that everyone has in their head that offers commentary all the way through the day, often is very negative and very that your worst enemy when it comes to trying to learn how to pace, because it says, oh, you should have been able to do this, you used to be able to do this, why can't you still do this, just push through. So it's that being kind, and I think if you can put yourself and think, if I was saying this to my best friend, would I be saying this same thing, is probably one of the ways that you can ease into it, because we do push through. We are hard on ourselves. It's something that we wouldn't do to someone we cared about, and yet we do it to ourselves. So it's practice, being kind, just saying, right, I'm going to do this, and when I start to feel breathless, I'm going to stop, because if I stop and listen to my body, then in an hour or 2 hours, I'll be able to go up and do a little bit more. But if I keep pushing through, I know I'm going to write myself off for the rest of the day. So it's a lot of self-talk, and it's about flipping what we say to ourselves inside in order for us to be able to achieve that.
We've got one more question that's come through, and that will be all we have time for today. Are there any ways to link with a psychologist who specialises in chronic disease like lung conditions, or through a GP?
So yes. Now, in terms of chronic conditions, so you would either want to see a clinical psychologist like myself, or a health psychologist. Now, many hospitals will have health psychologists as well as some clinical psychologists, although most respiratory departments don't have a psychologist. I would encourage you to ring the Australian Psychological Society, or they have a find a psychologist box on their website, where you can look at the various special interest areas of psychology in your area. And that's probably a good starting point. So you are going to be looking for a clinical psychologist or a health psychologist. And then when you phone the practice, ask if they have, chronic disease training. And in terms of respiratory training, it's not something that we do as psychologists. It's not something that we're taught when we're taught to be psychologists. And I'm actually trying to put together some form of training for psychologists if they would like to learn more, because for me, understanding lung disease has been absolutely invaluable to the people that I see in my practice.
Thank you so much for that. We will wrap up the questions there, as that is all we have time for today. I would like to thank everyone for taking the time to join us for today's webinar. I would again like to share my appreciation of Deborah for joining us, and would again like to acknowledge the Centre of Research Excellence in Pulmonary Fibrosis, who support us in holding these webinars. Before we finish the webinar, I would like to mention the services and resources that Lung Foundation offer for people living with PF and IPF. Most recently, the Life with Pulmonary Fibrosis resource was launched. You can access a hard copy of this resource by calling the Information and Support Centre on the 1800 number on the screen. A digital version is available on the Lung Foundation website, along with a number of IPF resources, including the IPF fact sheet. Some of you may be aware of the Lung Foundation's Peer Connect service, which aims to match people living with IPF or PF and their carers with someone going through a similar experience. This is a telephone-based service which can be accessed throughout Australia. If you would like to find out more about this service, please call the 1800 number on your screen. We will email out the recording on the complete webinar series along with an evaluation in the coming weeks. Your participation in the evaluation will be appreciated and will help us to shape future webinars. Again, thank you so much for joining us today for today's webinar, and we hope that you have enjoyed this year's series. We look forward to having you join us for the series next year.